Welcome to the Deep Dive. We sift through the layers, the research, the data to bring you, well, the surprising facts and insights that really matter. Today, we're looking at something incredibly fundamental. It's about the importance, the immense importance of a healthy start in life, and how one nation is taking on a, frankly, monumental challenge to make that happen. When we talk global health, you might think epidemics, chronic diseases, right? But there's this statistic that just stops you in your tracks. Neonatal mortality deaths in the first 28 days accounts for nearly two-thirds of all infant deaths in India. Just let that sink in, two-thirds. It's staggering. It highlights this huge human cost, a massive barrier for millions. Okay, so let's unpack this. Our deep dive today is into India's response. The India Newborn Action Plan, or INAP. It was launched back in September 2014. And this isn't just some policy document gathering dust. It's a really detailed blueprint designed specifically for India's unique complexities, its size, its diversity. And it has this incredibly ambitious goal, single-digit NMR by 2030.
That means getting the neonatal mortality rate down below 10 deaths per 1,000 live births. We're going to explore what makes INAP tick, how it's tailored, and what it really takes to chase equitable newborn survival on, well, an epic scale.
And that, for me, is exactly why this is such a crucial topic. Because when we talk about neonatal mortality, it's so much more than statistics. We're talking about profound human tragedy, lost potential, the heartbreak for families, and the ripple effects through society when newborns aren't protected. Every single one of those numbers is a future lost. What's also really interesting is that INAP wasn't created in a vacuum. It's directly linked to a global push. It aligns with the WHO-UNICEF Every Newborn Action Plan, ENAP, which also came out in 2014. ENAP was basically this global rallying cry, a unified call to end preventable newborn deaths and stillbirth everywhere. So our mission today, really, is to give you a clear, detailed look at INAP. We'll explore its core principles, its very layered intervention strategies, how progress is tracked, which is key, and the whole journey of putting it into practice. We'll look at the achievements, which are significant, and also the challenges that, well, they definitely still remain. Ultimately, this plan shows how targeted, multifaceted approaches, really rooted in local context and driven by equity, can make a massive life-saving difference.
Right. To really get why INAP is so significant, we have to understand the situation before it existed. The scale of the challenge was just immense. Like we said, nearly two-thirds of all infant deaths in India were happening in that neonatal period. Back in 2014, the neonatal mortality rate, the NMR, was hovering around 29 per 1,000 live births. That's not just a number. With India's population, its birth rate, that translates to hundreds of thousands of babies dying within their first month of life every single year. A huge loss. And here's where it gets really complex, maybe points to deeper issues. You'd think, okay, more healthcare access, more hospital births, things should just get better across the board, right? India had made strides in increasing institutional deliveries, more births were happening in clinics, in hospitals, and there were other child survival programs running. But despite all that, the neonatal mortality rate just stayed stubbornly high. It wasn't dropping as fast as you'd expect. So the big question was why? Why was that first month, those first 28 days, so incredibly vulnerable? Why was it such a bottleneck for overall infant survival, even with other improvements?
Well, that neonatal period is just uniquely fragile, isn't it? Newborns are incredibly susceptible. Things like complications from premature birth, birth asphyxia, lack of oxygen, and severe infections. They hit newborns really hard. Their immune systems are still developing, their bodies are tiny, small problems can escalate incredibly quickly. But it wasn't just the medical side. When you looked closer, it was also about the quality of care, even within those institutions. Was resuscitation immediate? Was basic hygiene consistently followed? Was there enough support right after delivery?
So access improved, but maybe not always the quality or the specific type of care needed right then.
Exactly. That paradox, more access, but still high vulnerability, really highlighted the need for something targeted, something comprehensive, like INAP. And this challenge, while huge in India, wasn't entirely unique. Globally, people were starting to realize that newborn deaths and stillbirths were kind of a blind spot in maternal and child health efforts. What's fascinating is how this global realization sparked a unified response. It led straight to the Every Newborn Action Plan, ENAP, from WHO and UNICEF in 2014. And ENAP wasn't just, another report. It was a major global initiative, a call to action specifically focused on ending preventable newborn deaths and stillbirths. The global targets were ambitious. Get the NMR down to 10 or less per 1,000 live births, and the stillbirth rate also to 10 or less per 1,000 births, both by 2035.
And having that global strategy, that must have been significant for countries like India.
Absolutely profound. ENAP provided that critical framework, that shared goal, but maybe even more importantly, it shifted the mindset. It really hammered home the idea that most of these deaths are preventable. They aren't inevitable tragedies.
Right, that term preventable is key.
It really is, because it implies action. It means if we have the right knowledge, the right interventions, the right resources put in the right places, we can avoid so many of these deaths. ENAP really ignited that belief and spurred countries to develop their own plans.
And India's response was, well, characteristically ambitious. In September 2014, right alongside ENP, they launched the India Newborn Action Plan, INP. But here's the really insightful bit. It wasn't just a copy-paste job. The plan explicitly states it was tailored to Indian epidemiological diversity. And that's huge, isn't it? Because India is just so incredibly diverse. The health challenges in Kerala are different from those in Bihar or in a remote tribal area versus a massive city.
Precisely. A one-size-fits-all approach just wouldn't work. You need that local adaptation.
And INP baked that in. But it also upped the ante. It set that dual target NMR and stillbirths rate, both below 10 per thousand. And the kicker, they aimed for 2030.
Yeah, 2030. 5 years ahead of the global ENAP target of 2035.
That really speaks volumes, doesn't it?
Yeah.
About the urgency, the commitment.
It absolutely does. It showed India wasn't just following a global trend. It was determined to lead, to accelerate progress for its own newborns.
So why was tailoring it to Indian epidemiological diversity so critical? We touched on the variety, but maybe unpack that a bit more.
Well, think about it. You might have high rates of, say, malaria impacting pregnancy in one state, while another might grapple with specific genetic conditions like thalassemia. Access to care is vastly different, too. A woman in a major city has different options than someone in a remote Himalayan village. Resources, staffing levels, cultural practices around childbirth, they all vary hugely.
So a uniform plan would just miss the mark in so many places.
Completely. It would be inefficient, maybe even ineffective. INAP's strength really comes from recognizing this diversity and building in the flexibility to adapt interventions based on local needs and, crucially, local capacity.
If we connect this to the bigger picture then, India's approach localizing the global plan, what does that tell us about running national health programs?
It offers a massive lesson, really, especially for large, diverse countries. It shows that local context isn't just a nice-to-have, it's paramount for success and sustainability. You know, one surprising implication, it fosters local ownership. When states and districts tailor the plan, local health leaders are empowered. They devise solutions that work for their communities using their resources smartly.
Instead of just trying to implement something decided miles away.
Exactly. Without that local tailoring, even the best global guidelines can just fall flat. They don't resonate, they don't fit the reality on the ground. INAP's success is really built on achieving global goals through deeply informed, locally driven action.
Okay, so an ambitious vision, tailored for diversity. But what holds it all together? INAP is built on 5 foundational principles. These aren't just buzzwords. They really shape how the plan operates. These are equity, universal coverage, convergence of maternal newborn child health, accountability, and community participation.
That's right. These are the bedrock.
So let's break these down. What do they mean in practice for people on the ground? Let's start with equity.
Equity is fundamental. It's the commitment that life-saving care must reach everyone, especially the most vulnerable. This means actively targeting resources and efforts towards remote areas, urban slums, tribal communities, marginalized groups, those who often get left behind. It's about ensuring socioeconomic status or geography doesn't determine a child's chance of survival.
So it's a moral point, but also practical. You can't hit national targets if huge groups are excluded.
Precisely. Then there's universal coverage. This is the aspiration, the goal, that every mother and every newborn, no matter where they are in India, should have access to essential, good quality health services. It marks a shift away from just focusing on specific diseases or interventions towards building a comprehensive system, a safety net for all.
Leaving no one behind, essentially.
That's the aim. The third principle, convergence of maternal newborn child health, is really critical too. It recognizes that health isn't segmented. A mother's health before she even gets pregnant affects the pregnancy. Her health during pregnancy affects the newborn. The newborn's health affects the child's long-term development.
It's all connected, a continuum.
Exactly. So INAP emphasizes integrating these services, a seamless continuum of care from preconception right through childhood and adolescence. It avoids those silos where the mother's care team doesn't talk to the baby's care team.
Makes sense. Then accountability. How does that work in such a huge system?
Accountability is crucial for making sure the plan actually delivers. It means having clear, transparent goals like the single-digit NMR target. It means robust data collection to track progress against those goals. And it means defining who is responsible for what at every level, from the national government down to the local health worker. This allows for monitoring, seeing what's working, what isn't, and making adjustments. It keeps everyone focused.
And the last one, community participation.
This is vital. It recognizes that communities aren't just passive recipients of healthcare, they need to be active partners. This means involving them in health promotion and monitoring local services, even in identifying local problems and finding solutions. When the community owns the plan, it's far more likely to succeed and be sustainable.
Okay, those 5 principles provide the why and the how. But given India's diversity, how did they actually structure the interventions themselves?
That's where the tiered approach comes in. This is a really smart part of INAP's design, addressing that exact question of diversity and resource variation. The interventions, which fall into 6 main packages we'll discuss, are classified into 3 tiers: Essential E, Situational S, and Advanced A.
E, S, and A. Okay, what does each mean?
Essential E interventions are the basics, the fundamentals. They're designed for universal application. Everyone, everywhere should get these. Think basic hygiene, essential vaccinations, core antenatal checks. Situational S interventions are applied more selectively. They depend on the specific local context, the disease patterns, the epidemiology of a particular region.
So tailored to local needs.
Exactly. If a region has high malaria rates, malaria prevention becomes an S intervention there. If another area has high rates of a specific infection, targeted screening might be an S intervention. It focuses resources where they're most needed based on data. And then advanced A interventions are for those states or districts that already have stronger health systems, more resources, more specialized capacity. These are often more complex, resource-intensive interventions.
Like neonatal intensive care units, perhaps.
Precisely. Things like NICUs, complex surgeries, advanced diagnostics, these fall under A. You implement them where the infrastructure and expertise can actually support them effectively.
That tiered approach sounds incredibly pragmatic for a country like India. Why is it so crucial?
Oh, it's absolutely vital because the disparities in India are enormous. Health infrastructure, number of doctors, nurses, specialists, it varies massively from state to state, even district to district. Trying to roll out, say, advanced NICU capabilities everywhere simultaneously would be impossible. Financially, logistically, it just wouldn't work. And it might even drain resources from essential services in poorer areas.
So it prevents overwhelming places that aren't ready.
Exactly. The tiered approach allows for really efficient resource allocation. It ensures the essential basics are available everywhere, it targets situational interventions based on need, and it concentrates advanced care where it can be delivered effectively and sustainably. It's adaptive, it's realistic, it acknowledges the different starting points across the country and builds capacity strategically. That makes the whole plan much more achievable and impactful.
Right, that makes a lot of sense. Could you give us maybe a quick example for each tier just to make it crystal clear for us listening?
Sure. So for Essential E, think about promoting immediate and exclusive breastfeeding within the first hour of birth. Universally beneficial, relatively low cost, hugely impactful for nutrition and immunity. The challenge is making it truly universal practice.
Okay, simple, but needs consistent effort everywhere. What about situational S?
For S, a good example is chlorhexidine application to the umbilical cord stump. INAP recommends this specifically in areas identified as having a high prevalence of neonatal sepsis, a deadly infection. They don't do it everywhere, only where the data shows it's most needed to prevent that specific risk.
Targeted prevention, got it. And advanced A.
For A, think about therapeutic hypothermia for babies suffering birth asphyxia, cooling the baby's body to protect the brain. This requires highly specialized equipment, continuous monitoring, expert staff. It can only be done effectively in well-equipped neonatal intensive care units and ICUs. So it's an A intervention available in centers with that capacity.
Perfect. That ESA structure really clarifies how they manage the complexity. All right, let's dive into the real substance now. The 6 strategic intervention packages of INAP. This is where the principles and the tiered approach translate into concrete actions. We'll start with package 1, setting the stage preconceptional and antenatal care. This one really shows INK's long view, starting before pregnancy. Under the essential E tier, the universal stuff, we see promoting adolescent health. and, critically, preventing early marriage and pregnancy.
Yes, and that's huge in the Indian context. Tackling early marriage isn't just a health intervention. It requires linking up with education, social welfare, legal systems, engaging communities. It's complex but foundational for maternal and newborn health.
Absolutely. It also includes universal antenatal registration, aiming for at least 4 A&C visits, promoting birth spacing, and crucial nutritional support like iron and folic acid, calcium, plus screening for common issues like hypertension, diabetes, anemia, infections, and tetanus immunization, standard essential building blocks.
Exactly, laying that strong foundation. Then, in the situational S-care for this package, INAP gets specific. For instance, screening for hemoglobinopathies like sickle cell or thalassemia, but only in regions where these genetic conditions are known to be common, where they're endemic.
Right, targeted screening based on local genetics.
Precisely. Or providing malaria prophylaxis during pregnancy, again, only in high endemic states. It avoids unnecessary medication elsewhere, but protects mothers and babies where the risk is high. Targeted screening for specific infections like hepatitis B or HIV might also fall here depending on local prevalence. It's all about using data to guide action.
And the advanced A tier for preconception and antenatal.
Here you see things like the use of more advanced diagnostics, maybe detailed anomaly scans using ultrasound to detect potential congenital issues early on, access to genetic counseling services, or even preconception counseling and fertility services in centers that can offer them. These are proactive, specialized services for those with access to higher levels of care.
Okay, moving to package 2. The critical window care during labor and childbirth. This feels like a really intense focus point.
It absolutely is. What happens in those hours around birth is critical. So many risks can be managed right then and there. The essential E interventions here are non-negotiable. Top of the list, skilled birth attendants SBA at all deliveries. Having someone properly trained makes a massive difference.
Not just anyone, but someone skilled.
Exactly. And ensuring clean, safe delivery practices basic hygiene saves lives. Using a partograph to monitor labor progress helps identify problems early. Also crucial is active management of third stage of labor, AMTSL, to prevent postpartum hemorrhage in the mother, which keeps her stable for the baby, and having resuscitation corners ready for immediate newborn resuscitation if needed. Use of corticosteroids if preterm birth is anticipated to help mature the baby's lungs.
All absolutely vital actions right at the point of birth. What about situational S?
An interesting example here is the guideline on using antenatal corticosteroids for preterm labor. It's recommended, but primarily where neonatal intensive care facilities are actually available to manage the premature baby afterwards.
So the intervention is linked to the capacity to handle the outcome.
Precisely. It's no good helping the lungs mature if there's no ventilator or specialized care available if the baby still struggles. It shows that resource-aware planning.
And advanced A for labor and delivery.
This is where we see comprehensive emergency obstetric and neonatal care, CEMONC centers. These are facilities equipped to handle any major complication for mother or baby, 247 C-sections, blood transfusions, advanced neonatal care.
The top-level emergency hub.
Exactly. And also the use of more advanced technology for monitoring during labor, like continuous electronofetal heart monitoring devices, to get real-time data on the baby's condition. These are resource-intensive but crucial for complex cases.
Got it. Now, package 3. First moments matter, immediate newborn care, those first minutes and hours. The essential E list here seems full of simple but powerful things, like delayed cord clamping.
Yes, allowing more blood volume to transfer to the baby. Simple but beneficial.
Preventing hypothermia, keeping the baby warm through drying, immediate skin-to-skin contact with the mother, delaying the first bath.
Crucial, especially for smaller babies or in cooler environments. Skin-to-skin is incredibly effective for warmth, bonding, and stabilizing the baby.
And early initiation of breastfeeding, ideally within the first hour, plus giving vitamin K1 injection to all newborns to prevent bleeding disorders.
All fundamental evidence-based practices that should happen for every single baby, everywhere.
The situational S intervention mentioned earlier fits here, right? The chlorhexidine cord application.
Yes, exactly. Applying chlorhexidine antiseptic to the umbilical cord stump, but specifically targeted to those areas with a high prevalence of neonatal sepsis based on epidemiological data. A perfect example of a situation-specific preventative measure.
And for advanced A, immediate care.
Here we see things like the use of point-of-care diagnostics, maybe rapid tests for newborn infections right at the bedside, and importantly, universal newborn screening programs. This means screening all newborns, usually before discharge, for conditions like hearing loss or certain metabolic disorders, like hypothyroidism.
Why is that advanced? It sounds essential.
It's advanced because setting up and running a truly universal screening program is a massive undertaking. It requires labs, sophisticated testing equipment, tracking systems, and crucially, established pathways for follow-up diagnosis and treatment for any baby who screens positive. The logistics and cost put it in the A category for systematic implementation, even though the principle is vital. Early detection here can prevent lifelong disabilities.
Okay, that makes sense. Let's move to package 4.
Yeah.
Nurturing growth care of healthy newborn. So care continues after those first critical hours.
Absolutely. Survival is just the start. The essential E interventions here focus on supporting that healthy growth, top of the list. Promoting and supporting exclusive breastfeeding for the first 6 months, continued reinforcement of that message. And kangaroo mother care, KMC, that skin-to-skin contact not just immediately after birth, but as ongoing care, especially for low birth weight babies. It's incredibly effective for growth, temperature regulation, and reducing infections. ASAs play a huge role in supporting KMC at home.
Community health workers are key there.
Absolutely. Also essential are completing the full immunization schedule as per national guidelines and the home-based newborn care HBNC program. HBNC involves trained community health workers, usually ASAs, visiting newborns at home multiple times in the first weeks to check on the baby, support breastfeeding, identify danger signs, and refer if needed. It extends care right into the home.
A vital link. What about situational S in this package?
This might involve special targeted counseling in areas where non-recommended breastfeeding substitutes are commonly used due to cultural beliefs or other factors, providing culturally sensitive education to promote exclusive breastfeeding in those specific contexts.
Addressing local barriers directly.
Yes, and for advanced A, care for healthy newborns. Think specialized lactation management centers, perhaps located at district hospitals, for mothers facing significant breastfeeding challenges who need expert help. And leveraging technology using e-health platforms or telecounseling to provide ongoing support and advice to families, especially those who might be far from a health facility, using tech to bridge gaps.
Okay, package 5 feels crucial. Package 5, supporting the vulnerable care of small and sick newborn. This is the safety net. The essential E tier here lays out a network of facilities. It starts with newborn care corners, NBCCs, at all delivery points.
Right, for that immediate resuscitation and basic stabilization, even at primary health centers.
Then newborn stabilization units, NBSUs, at community health centers, CHCs, for short-term care. And the big one, special newborn care units, as NCUs at district hospitals.
SNCUs are the workhorses for sick newborn care at the district level. They can manage many common problems like prematurity, sepsis, jaundice. Establishing and equipping these across India was a massive undertaking under INAP and related programs.
And this tier includes the integrated management of neonatal and childhood illnesses, IMNCI approach.
Yes, IMNCI provides standardized guidelines for health workers to assess, classify, and treat or refer sick newborns and children. It's a systematic way to ensure common illnesses are managed correctly, and crucially, referral transport reliable ambulance services like the 102-108 system to get sick babies to higher facilities quickly.
That whole system needs to work together. What about situational S for sick newborns?
Here we see more specialized medical interventions deployed based on need and capacity. For example, using surfactant therapy to help underdeveloped lungs in premature babies, or using CPAP, continuous positive airway pressure, for respiratory support. These would typically be available in SNCUs or higher centers, particularly in states with a higher burden of preterm births. Also, using specific antibiotics guided by local antimicrobial resistance patterns, choosing the right drug based on what bugs are common and resistant in that area.
Smart antibiotic use. And advanced A.
This is the highest level, neonatal intensive care units, NICUs. These have ventilators for full respiratory support, advanced imaging like cranial ultrasounds or MRIs, pediatric surgeons on call, and the ability to provide highly specialized therapies.
Like the therapeutic hypothermia we mentioned.
Exactly. Or exchange transfusions for severe jaundice. These are life-saving interventions for the most critically ill infants, requiring the highest level of expertise and technology, typically found in tertiary care hospitals or medical colleges.
A comprehensive ladder of care. Finally, package 6, beyond newborn survival long-term care and development,
looking beyond just getting through that first month.
Yes, this is crucial. If we connect this to the bigger picture, INAP recognizes survival isn't the only goal. Quality of life and optimal development matter hugely. So the essential E tier includes promoting early childhood development services, screening for developmental delays and disabilities so interventions can start early, and importantly, linking families with existing national programs like the Integrated Child Development Services, ICDS, which provides nutrition and preschool education, and the Rashtriya Bal Swasthya Karyakram, RBSK, which screens children for defects, diseases, deficiencies, and developmental delays. It integrates newborn care into the broader child health system.
Leveraging existing structures. What about situational S?
This could involve state-specific programs targeting conditions that are particularly prevalent in that state and impact long-term development. For example, a state might run a dedicated program for screening and managing congenital hypothyroidism or hearing impairment if those are major local issues.
States taking initiative based on their data.
Right. And the advanced A tier focuses on specialized support for children with long-term needs. This includes pediatric rehabilitation centers, early intervention clinics providing therapies like physiotherapy or speech therapy. It also involves research into child development and using digital tools for more sophisticated growth monitoring and tracking developmental milestones. It's about ensuring even children born with challenges can reach their full potential.
Wow, that's an incredibly detailed set of interventions across all those packages and tiers. But a plan is only as good as its execution and monitoring, right? So, Section 4, the engine of progress, monitoring, and implementation. How do they track all this?
You're absolutely right. The monitoring framework is critical. It's built around that RMNCH plus a continuum reproductive, maternal, newborn, child, and adolescent health, recognizing the connections across the life course. They use different types of indicators.
Yeah.
The input indicators track the resources. Are the staff trained? Is the equipment functional? Are drugs available? Basically, is the system ready?
To the building blocks.
Then process indicators track the actions. Are pregnant women getting their A&C visits? What percentage of births are attended by skilled personnel? Are newborns getting vitamin K? Is the system actually doing what it's supposed to do?
Measuring the activity.
Exactly. Output indicators look at the immediate results. What percentage of newborns initiated breastfeeding within an hour? How many low birth weight babies received KMC? How many sick newborns were successfully referred and treated?
The direct results of the actions.
Right. And finally, the bottom line, outcome indicators. This is where we see the neonatal mortality rate, the stillbirth rate. Are we actually achieving the ultimate goals of saving
It
lives?
sounds like a really comprehensive dashboard tracking everything from supplies to survival rates. How do they actually collect all this data and ensure quality?
They use several mechanisms working together. One really important one is facility-based maternal and perinatal death surveillance and response, or MPDSR. This isn't just counting deaths. It involves reviewing every single maternal and perinatal death that happens in a health facility to understand exactly why it happened, were there delays, system failures, gaps in care. The goal is to learn from each tragedy to prevent future ones.
Learning from mistakes systemically.
Precisely. Then there are periodic supportive supervision visits. Senior officials regularly visit facilities, not just to inspect, but to mentor staff, check quality of care, troubleshoot problems, and ensure guidelines are being followed. It's hands-on oversight.
Quality control and support.
Yes. And the Health Management Information System, HMIS, is the backbone for routine data. Health workers across the country report data on services delivered, which gets compiled digitally. This allows for near real-time tracking of indicators, identifying trends and problem areas quickly. Though ensuring data quality across such a vast system is, of course, an ongoing challenge.
I can imagine. Real-time data is powerful, though.
Extremely. And finally, they emphasize community-based monitoring. Village Health Sanitation and Nutrition Committees, VHSNCs, are empowered to oversee local health services, provide feedback, and hold providers accountable. It brings monitoring right down to the grassroots level.
So, multiple layers of checking and feedback. How do you actually manage a system like that effectively across all of India?
That multi-layered approach is the only way, really. It provides checks and balances. HMIS gives the broad numbers. Supervision visits check the quality behind the numbers. MPDSR dives deep into critical failures. And community monitoring ensures local relevance and accountability. It allows for adaptive management. If HMIS shows vaccination rates dropping in a district, supervisors can investigate why. If MPDSR reveals repeated issues with resuscitation, training can be strengthened. It allows the system to learn and adjust continuously. Without it, INAP would just be a plan on paper.
Okay, that explains the how of tracking.
Mm-hmm.
But how does a national plan like INAP actually get rolled out on the ground in, say, different states?
That's where decentralization comes in. INAP wasn't just imposed from the top down. States were actively encouraged, even required, to develop their own state newborn action plans, or SNAPs.
That's the net piece.
Yes. These SNAPs had to align with the national INAP framework, obviously, but they were then further contextualized at the district level by district health societies. So a district would look at its specific disease burden, maybe they have a lot of preterm births or a particular infection is common, and look at the readiness of their health system, how many functioning SNCUs do they have, what's the staffing situation, and they'd tailor their implementation plan accordingly.
So the national plan sets the direction, but the states and districts figure out the specific route.
Exactly. It allows for that crucial flexibility and local relevance we talked about. A district with lots of remote, hard-to-reach areas might prioritize strengthening outreach services, while an urban district might focus on upgrading facility infrastructure.
And this decentralized approach still kept that focus on equity.
Yes, that was a core instruction. States and districts were explicitly told to target implementation efforts towards high-priority districts, which often had the worst health indicators, as well as tribal areas and urban slums, places where vulnerability is high and access has historically been poor.
So prioritizing the neediest areas within that decentralized framework.
Precisely. It's about ensuring that decentralization doesn't just mean easier areas get better faster. It means empowering local areas to tackle their biggest challenges, with a specific focus on reaching the underserved. It addresses equity head-on within the implementation strategy. It's a smart way to manage diversity and drive equitable progress.
Okay, so we've got the plan, the interventions, the monitoring, the implementation strategy. It all sounds incredibly comprehensive. The big question then is, has it worked? What does the journey look like so far? Let's talk achievements and hurdles.
And there are definitely significant achievements to talk about. The data shows remarkable progress since INAP was launched.
Let's get to the headline number then, the neonatal mortality rate. Where did it start and where is it now?
Right. So when INAP launched in 2014, the national NMR was around 29 deaths per 1,000 live births. By 2022, that number had fallen to 19 per 1,000 live births.
19, wow. That's a drop of 10 points in less than a decade.
It's a substantial reduction. And what's fascinating, as you say, is the speed and scale of this progress in a country as vast and complex as India. It really is a testament to the concerted effort.
It shows that these comprehensive strategies, the essential care, the situational adaptations, the advanced care where possible, all backed by monitoring, they can make a massive difference.
Absolutely. And we need to remember what that 10-point drop actually means in human terms.
Yeah, it's easy to get lost in the numbers.
But given India's birth cohort, reducing the NMR from 29 to 19 means hundreds of thousands of babies' lives have been saved each year compared to the baseline. Hundreds of thousands of families spared that unimaginable loss.
That really puts it in perspective. Hundreds of thousands of children getting a chance at life.
It's a validation of the approach. Better management of prematurity, better infection control, improved care at birth, the expansion of facilities like SNCUs, the work of ASHAs, it all contributes. It shows the 2030 goal of single-digit NMR, while still ambitious, is potentially within reach with sustained effort.
That's genuinely impressive progress. But like any major public health undertaking, I assume the journey hasn't been entirely smooth. There must still be hurdles.
Oh, definitely. Despite the success, significant challenges remain. The work is far from over.
So what are the main sticking points? The things that still need focused attention?
Well, one major issue is that disparities persist between states. While the national average NMR has dropped to 19, some states are doing much better, already approaching or even below the single-digit target. But others, particularly larger states in the North and East, are still lagging significantly behind, with NMRs well above the national average.
So the progress hasn't been uniform across the country.
Not at all. And this points to ongoing issues with uneven resource distribution, maybe differing levels of political will or administrative capacity at the state level, and deeper socioeconomic factors that make progress harder in some areas. Closing these equity gaps between states is a huge priority.
What else?
Another major challenge is the shortage of specialized human resources and infrastructure gaps. Neonatal care requires highly trained doctors, nurses, and technicians. Recruiting and retaining these specialists, especially pediatricians and neonatologists, in district hospitals or rural areas is incredibly difficult. You might have a shiny new SNCU building, but if you can't staff it adequately 24/7 with trained personnel, its effectiveness is limited. Many SNCUs face staff vacancies or rely on general doctors trying their best.
The people problem is often harder than the building problem.
Often, yes. And linked to that is ensuring consistent quality and maintenance of infrastructure and equipment in all these facilities across the country.
Okay, disparities, human resources. What's next?
A really significant barrier for families is high out-of-pocket expenditure, OPE. Even though public health care is ostensibly free, families often end up spending considerable amounts.
How so?
Costs for travel to facilities, especially for multiple visits or prolonged stays if a baby is in an SNCU. Costs for medicines or supplies that might not be available at the facility pharmacy. Lost wages for parents who have to take time off work, sometimes even informal payments.
So accessing care can push families into debt.
Exactly. It can be catastrophic, especially for the poorest families. This financial burden can be a major barrier to seeking or completing care, undermining the goal of universal access. Reducing OPE is critical for equity. Finally, we have those deep-rooted, persisting social determinants. Things like maternal malnutrition, which leads to more low birth weight babies. The ongoing issue of early marriage and adolescent pregnancy, driven by complex social and economic factors, which increases risks significantly. And pervasive gender bias, which can subtly or overtly influence decisions about seeking care for baby girls versus baby boys. These aren't things the health system alone can fix.
Right. These go way beyond the hospital walls. Malnutrition, child marriage, gender discrimination. These require much broader societal change, don't they?
Absolutely. They require action across multiple sectors: education, women's empowerment, poverty reduction, nutrition programs. The health sector can mitigate some effects, but truly tackling these determinants needs a whole-of-society approach. They represent some of the most stubborn barriers to achieving the final goals.
It shows that these aren't just technical or logistical problems. They're deeply interwoven with the social fabric. Addressing them is key for sustained progress, not just in newborn survival, but overall well-being. #outro.
So as we wrap up this deep dive, the central message really is that INI represents India's powerful, ongoing commitment to ensuring that truly every newborn counts. It's a plan born out of a huge challenge, aligned with global goals, but uniquely tailored for India. We've seen its remarkable progress, saving hundreds of thousands of lives. Its strength really lies in that combination. Universal essential care for all, layered with targeted situational interventions based on local data, and advanced care where possible. And all of it underpinned by that robust, multi-level monitoring and accountability system. This whole structure has driven the impressive fall in neonatal mortality, and it remains the foundation for pushing towards that ambitious single-digit NMR target by 2030. It's a real case study in strategic public health action.
It absolutely is. So what does this all mean for you, thinking about health strategies, whether in India or elsewhere? We've seen the incredible power of a well-designed, comprehensive plan. We've seen the life-saving impact of targeted interventions and strong monitoring. But we've also touched on those persistent, almost foundational challenges, these social determinants: malnutrition, early marriage, gender bias issues that medicine alone can't fully solve. So here's a final thought to leave you with, something to maybe reflect on. Given the huge strides made through INAP and yet the stubborn persistence of these deep social factors, what fundamental shifts in attitudes, in cultural practices, in policies beyond just health do you think are most crucial now to truly ensure every newborn counts, not just in India, but anywhere facing similar challenges? It's a reminder, isn't it, that achieving true health equity requires more than just good health care. It demands addressing the very roots of vulnerability within our societies. Thank you for joining us on The Deep Dive.